approach to diagnose of cholecystitis. Let's try some questions first. Doctors, by the time we are done, gallbladder disease should not be a problem. You should go into the MCCQE1 exam and be able to ace every gallbladder disease because of the systematic nature of how we are approaching it. So let's try some questions. I want somebody to read this question for us, please. Who's going
A
to read for us?
45-year-old woman presents with right upper quadrant pain, fever, and leukocytosis. Ultrasound shows gallbladder wall thickening and pericholecytic fluid, but no stones. Which of the following additional findings would most strongly support a diagnosis of acute cholecystitis? A. Presence of air in the gallbladder. B. Positive Murphy's sign on ultrasound. C. Non-visualization of the gallbladder on oral cholecystography. D. Hyperbilirubinemia with elevated liver enzyme. And the answer.
So what's your answer?
Will be B.
B. Positive Murphy's sign on ultrasound. Positive Murphy's sign on ultrasound. We are getting to the site of glory so far as gallbladder disease is concerned. So a positive sonographic Murphy's sign where the patient experiences pain during palpation with the ultrasound transducer is a strong indicator of acute cholecystitis and is more accurate than hand palpation. Now, presence of air in the gallbladder wall suggests emphysematous cholecystitis. Non-visualization on oral cholecystography is not relevant in the acute settings. And remember that in the MCCQE1 exam, you are being tested on what are the next best step. So, just hold on with all the highfalutin stuff like oral cholecystography. And hyperbilirubinemia may indicate choledocholitis rather than acute cholecystitis. So you see, doctors, the reason why we choose specific answers in a question stem when we are learning is because we are informed. We are not just choosing, for choosing sake. We are informed. Okay, I need someone else to read this question for us. Let's go, class. Let's go.
In a patient with suspected acute cholecystitis, the ultrasound shows gallstones, but is inclusive for gallbladders wall thickening or the pericholecystic fluid. What is the next best imaging modalities to confirm the diagnosis?
Beautiful. So this is a very, very important question. So now you realize that we are going deeper. Suspected acute cholecystitis, ultrasound shows gallstones, but is inconclusive for gallbladder wall thickening and pericholecystic fluid. Because we've already said that with, acute and chronic cholecystitis, there'll be gallbladder wall thickening, there'll be a stone. If it's a calculous cholecystitis, fever, leukocyte. But then this question says that it's inconclusive for gallbladder wall thickening or pericholecystic fluid. What's the next best imaging modality? So when you've done your ultrasound and the ultrasound is inconclusive, what's the next best step? That's the question. So are you going for MRCP? Are you going for abdominal CT? Are you going for polyscintigraphy? Or are you going to go for endoscopic retrograde cholangiopancreatography? Which one are you going to go for? And the answer is a HIDA scan. Now, the teaching point is this. If the ultrasound is inconclusive, HIDA scan or polyscintigraphy is the next best step to confirm the diagnosis of acute cholecystitis. MRCP is more useful for detecting choledocholitis. CT scan is often used to rule out complications, and ERCP is reserved for therapeutic interventions rather than the primary diagnosis. So let's take it again. MRCP is more useful in detecting choledocholitis. So choledocholitis means the stone has left. It's now in the it's now down there, and it's left, and it's caused dilatation of the biliary duct. Complications like gangrene and all those things can be picked up with CT, and I'm going to explain it. And then ERCP is usually reserved for therapeutic interventions. So if you say somebody has like cholecystitis and they do the ultrasound, I pick this image from the internet. These are the features. You see gallbladder wall thickening. You will see pericholecystic fluid. You will see presence of gallstones. And then you see sonographic Murphy's sign. So that is the gallstone there. There will be some pericholecystic fluid, gallbladder wall thickening. In most cases, the diagnosis can be established with an abdominal ultrasound. Okay. Now, when are you going to do a HIDA scan? So now we are moving to next best steps in investigation. Next best steps in investigation. We said that if we can't, you're not sure, we go for HIDA scan. Why? If the ultrasound is inconclusive, consider additional imaging. And that additional imaging you want to consider is hepatobiliary immunodiacetic acid scan. That is HIDA scan. That is HIDA scan. So we are learning next best step tricks so far as investigations are concerned. Remember, we did next best step tricks so far as management was concerned. Next best step trip so far as investigations are concerned. Now, when are we going to request for abdominal CT scan and abdominal MRI? Use abdominal CT and MRCP when you suspect complications and when you want to rule out alternative diagnosis. Those two. So next best step, if you are not sure, HIDA. If you think complications, and what are some of the complications? Gangrene, gallbladder wall perforation, Mirinzi. You want to do CT or MRCP. So doctors, when you see those words, at times go because you're not a general surgeon or you're not a gastroenterologist, go like, oh my goodness, what am I going to do? But if you just follow these steps, HIDA, what am I going to do? A HIDA scan. What am I going to do? MRCP. What am I going to do? CT scan. I'm good. Now, back to laboratory investigation. So now that we've gone through next best steps in investigation, next best step in imaging, what are the lab investigations you want to do? Patient comes in, right upper quadrant pain. What are your labs? You want to do a CBC. Why? Because you are going to look for leukocytosis with a left shift. And at times you may look for band formation. As long as you see band formation, you think, hey, this patient is becoming septic. Serum lipase and amylase. Why? Because a differential diagnosis of acute cholecystitis is acute pancreatitis. Electrolytes. Why? Because the patient can have an electrolyte abnormality. Alanine aminotransferase. Why? And then aspartate aminotransferase. So AST, ALT. Why? Because we learned that even bilirubin, because we learned that usually in acute cholecystitis, total bilirubin will be normal. ALP will be normal. As soon as I see elevation in ALP, as soon as I see elevation in bilirubin, it should start causing me to think, hey, this patient may have something else. And please, who can remind me of those conditions which occur in the context of elevated ALT and elevated bilirubin? Who can help me? We mentioned about 4 of them.
Acute cholangitis.
Cholangitis, yes.
Biliary obstruction.
Biliary obstruction, yes.
Emphysematous cholecystitis.
And there was a last
Cholelithiasis.
Cholecystitis. Miresis. Sure. So, now we are building. So serum calcium must also be checked, serum albumin, and pregnancy test in a female with reproductive potential. Remember, if the patient is a female, reproductive potential, and has any form of abdominal pain, whether right upper, lower, wherever, make sure that you also do your pregnancy test.